Hello, today we will discuss endometrial hyperplasia. The endometrium is the uterine lining or the innermost layer of the uterus. The other layers are myometrium and perimetrium. Endometrial hyperplasia is an abnormal thickening of the endometrium, suspected when the endometrial thickness is more than 5 mm or 5 mm in postmenopausal women, and more than 1 cm in premenopausal women. In some cases, it is associated with malignancy. So endometrial hyperplasia is a pathological condition characterized by hyperplastic changes in endometrial, glandular, and stromal structures lining the uterine cavity. Endometrial hyperplasia, particularly with atypia, is a significant clinical concern because it can be a precursor of endometrial cancer. The incidence of endometrial hyperplasia is 133 women per 100,000 per year. Most cases occur after menopause in women from 50 to 54 years of age. Atypical hyperplasia is seen most commonly in 60 to 64 years olds. Estimates of incidence are believed to be low because many women do not report their symptoms or report only after symptoms remit. Also, endometrial hyperplasia occurs mostly in postmenopausal women. It can occur at much younger ages when estrogen is unposed as seen in polycystic ovarian syndrome and obesity. Body of uterus and endometrium. Diseases of uterus usually result from endocrine imbalances, complication of pregnancy, and neoplastic proliferations. Classification of the World Health Organization 94 based on glandular complexity and nuclear atypia. Non-atypical endometrial hyperplasia, simplex and complex. Atypical endometrial hyperplasia, simple and complex. And another classification of 2014 divide hyperplasia in two groups, benign hyperplasia and atypical hyperplasia, or endometrial intraepithelial neoplasia. The World Health Organization 2014 SHIM is more likely successfully identify precancerous lesions than the World Health Organization 94 classification. Estimated risk of progression of atypical hyperplasia to the endometrial cancer is 8 to 29%. In category, we divide simple endometrial hyperplasia without atypia. Simple is described as a mild increase in gland number that may show mitosis. Complex has increase in gland-to-stroma ratio greater than 50% with cellular disorganizations. Cells usually show mitosis, and atypia is represented by nuclear enlargement, abnormal chromatin, and polymorphism. An endometrial hyperplasia defines an increased proliferation of the endometrial glands relative to the stroma, resulting in an increased gland-to-stroma ratio when compared with normal proliferative endometrium, an important cause of abnormal bleeding. And endometrial hyperplasia associated with prolonged estrogen stimulation of the endometrium have the malignant potential of endometrial hyperplasia. Risk factors for endometrial hyperplasia: it's estrogen replacement therapy, polycystic ovary syndrome, estrogen producing tumors, irregular menstrual periods, premenopause period, overweight, and diabetes mellitus. Signs and symptoms for endometrial hyperplasia. Abnormal uterine bleeding is the most commonly reported sign. Additional symptoms may include menorrhagia, its increased blood loss greater than 80 milliliter or bleeding that lasts longer than 8 days. Menometrorrhagia, increased irregular bleeding, so of as mix of menorrhagia and metrorrhagia, and postmenopausal bleeding. It's any amount of vaginal bleeding, including spotting or staining after a woman had already experienced a case in menstruation due to menopause. When it comes to pathogenesis of endometrial hyperplasia, endometrial hyperplasia is caused by increased amount of estrogen unposed by progesterone. In normal cycle, estrogen is released from the ovaries, which induces the endometrium to proliferate in preparation for implantation. Ovulation causes progesterone to increase, which stabilizes and prepares the endometrium for possible implantation. If no implantation occurs, then both estrogen and progesterone level decrease and menstruation occurs. As a woman ages and reaches premenopause and menopause, ovulation occurs less often or not at all. Due to the lack of ovulation, there is a loss of progesterone, counteract remaining estrogen. Estrogen then allows for increase and unposed growth of the endometrium. So hyperplasia usually develops in presence of continuous estrogen stimulation unposted by progesterone. The female hormone estrogen and progesterone controls the changes in the uterine lining. Estrogen builds up the uterine lining. Progesterone maintains and controls this growth. Estrogen without enough progesterone may cause lining of the uterus to thicken. With increase of proliferation come risk for abnormal changes in nuclear, how we call it atypia. Atypia is associated with change as high as 60% of having or developing endometrial cancer. However, in many cases, hyperplasia regrets on its own. In malignancy develops, most cases are type 1 endometrial adenocarcinomas, which have more favorable outcomes. Simple endometrial hyperplasia without atypia, also known as cystic or mild hyperplasia, is characterized by glands of various sizes and irregular shape with cystic dilatation. You can see it in the picture. Mild increase in the gland stroma ratio. The epithelial growth pattern and cytology are similar to those of proliferative endometrium. These lesions uncommonly progress to adenocarcinoma, probably 1%. It largely reflects a response to persistent estrogen stimulation. Complex hyperplasia without atypia. There is an increase in the number and size of endometrial glands. Marked gland crowding and branching of glands. Glands may be crowded back to back with little interweaving stroma, abundant mitotic figures. Glands remain distinct and not confluent, and the epithelial cells remain cytologically normal. This class of lesion has about a 3% progression to carcinoma. Atypical hyperplasia, simple and complex. Simple atypical hyperplasia is rare. Cells with nuclear atypia show loss of polarity and increase in the ratio. The nuclei are enlarged, nuclear irregular inside and shape, vesicular chromatin, second irregular nuclear membrane, you can see in the picture, and prominent nucleoli. Nuclei tend to be round as compared with the oval nuclei of proliferative endometrium and hyperplasia without atypia. Studies have raised doubts about the clinical significance of the architectural categories in this classification system. Endometrial hyperplasia could be simply subdivided into broad categories: hyperplasia without cystologic atypia and hyperplasia with cystologic atypia. It has been seen that fewer than 2% of hyperplasia without cytologic atypia progress to carcinoma, whereas 23% of hyperplasias with cytologic atypia progressed to carcinoma. In general, WHO system correlates well with the risk of progression to endometrial carcinoma. However, a major limitation of this system is the intra and intra-observer variability in the identification of atypia. Thus, grading atypia as mild, moderate, or severe is not recommended. It is subjective and not reproducible. It has been proposed that endometrial perforations can be broadly divided into categories based on the molecular genetic analysis of clonality. Polyclonal lesions are regarded as a response to an abnormal hormonal environment and are designated hyperplasia. Monoclonal lesions are associated with an increased risk of progression to carcinoma and are designated endometrial intraepithelial neoplasia. Almost half of apparently normal women contain a small fraction of mutant endometrial glands. This latent phase may persist for years with continued presence of scattered and interspersed mutant glands. Endocrine factors act upon these latent precancers to modulate involution or progression to endometrial intraepithelial neoplasia. Transmission to endometrial neoplasia requires accumulation of additional genetic damage in at least one latent precancer cell. This cell colonially expands from its point of origin to form a contiguous grouping of tightly packed and cytologically altered glands recognizable as intraepithelial neoplasia. Endometrial hyperplasia changes typically observed with anovulation or other etiology of prolonged exposure to estrogen. The morphology of endometrial hyperplasia varies from proliferative endometrium with a few cysts, persistent proliferative endometrium, to bulkier endometrium with many dilated and controlled glands. In other systems, these have been designated as cystic glandular hyperplasia, mild hyperplasia, or simple hyperplasia. Endometrial intraepithelial neoplasia, a premalignant clonal neoplasm, precursor of endometrial carcinoma. It's not subdivided into grades, is different than diffuse hormonal effects, Endometrial intraepithelial neoplasia system categories do not correspond directly to specific categories in the WHO system, but there is some consistency. Most simple and some complex hyperplasia fall in the endometrium category. Many complex hyperplasia without atypia and most complex hyperplasia with atypia fall into the endometrial intraepithelial neoplasia. Clonal organ of endometrial intraepithelial neoplasia lesion is responsible for their localized distribution in the majority of cases at the time of diagnosis. Only about 20% of EIN lesions at diagnosis have extended to involve the entire endometrial compartment. EIN lesions emerge from all of these categories, but at different likelihoods. Frequency of different types of hyperplasia is not equivalent, so they disproportionately contribute to the final EIN pool. In all rediagnosed EIN lesions, 63% come from atypical hyperplasia category, 27% from the complex non-atypical hyperplasias, and only 10% from simple non-atypical hyperplasias. Cytologic feature of intraepithelial neoplasias. There's no absolute standard for cytologic features of EIN lesions. Cytology of architecturally crowned area is different than background or clearly abnormal. The manner of cytologic change in EIN varies considerably from patient to patient. Changes not be limited to increased variation in nuclear size and contour, chromatin texture, change in nucleoli, change in nuclear ratio, and altered cytoplasmatic differentiation. A fixed presentation of systolic atypia is not a prerequisite for intraepithelial neoplasia. Attempts to define an absolute standard are confounded by extreme morphological plasticity of endometrial glandular cells under changing hormonal repair and differential conditions. A minimum number of adjacent glands is required for an accurate assessment. The minimum lesion size to achieve elevated cancer risk is a diameter of 1 millimeter. Lesions of lesser dimensions should be considered subdiagnostic. For purposes of size measurement, the lesion perimeter is defined by that region in which the gland density is sufficiently high. Lesion diameter is measured from one perimeter edge to the other with a single fragment. Several common artifacts are observed in endometrial biopsy. Some of these may be misinterpreted as endometrial hyperplasia or even as carcinoma, if not appreciated to be artifactual. Telescoping refers to glands within glands and is commonly seen. Artifactual crowding and compression of glands may result in consideration of a complex endometrial hyperplasia. With this artifact, the glands become molded together and often there is tearing of the tissue around the glands, which is a clue to the artifactual nature. An artifact that is especially common with, but not exclusive to biopsy specimen or outpatient is the presence of superficial strips of endometrium with a pseudopapillary architecture. Endometrial breakdown. Loss of estrogen leads to mitotically quiescent glands or tissue with massive stromal breakdown. Altered cytology is due to peeling up epithelial cells unsupported by stroma. Associated nuclear changes such as loss of polarity, which may be accentuated under certain fixation conditions. Symptoms of endometrial hyperplasia: its vaginal discharge, abdominal pain, bleeding between menstrual periods, heavy or prolonged menstrual periods. When it comes to treatment, therapy depends upon the type of hyperplasia and the patient's desire for future fertility. Without atypia, there's a 1 to 3% chance that hyperplasia will progress to endometrial cancer. Progestin therapy is the most accepted method for the treatment of endometrial hyperplasia without atypia. Progestin can be given orally or released from intramuscular injections or intrauterine device. First-line therapy includes oral roxyprogesterone. Mixed estrogen, progestin, oral contraceptives can be used in some patients. So 10 milligram methoxyprogesterone acetate for 10 to 14 days a month for 3 to 6 months. If they have a normal biopsy and are asymptomatic, discontinue therapy. If the hyperplasia is persistent, then continuous dose progestin therapy is instituted with 20 milligram per day for 3 to 6 months. In women desiring contraception, oral contraception can be used or an injectable depot preparation of medroxyprogesterone acetate can be administered in the normal dose used for contraception, 150 milligrams every 12 weeks. Also, Mirena levonorgestrel intrauterine device have been shown to be very effective in the treatment of endometrial hyperplasia and offer long-term contraception. Endometrial hyperplasia with atypia has a greater risk of progressing to cancer. If future pregnancy is not desired, then hysterectomy is the best and definitive treatment. In postmenopausal women, bilateral salpingo-oophorectomy is recommended also. If pregnancy is desired, then progestin therapy is used when surgery, even conservative, will not allow for pregnancy. Progestin can be given orally or released from intramuscular injections or intrauterine device. So typically 20 milligrams of medroxyprogesterone acetate daily is given to patient. Another option is 40 to 160 milligram megestrol acetate daily for 6 months. An intramuscular depot medroxyprogesterone injections 4 times a year has shown to be effective. Here also intrauterine device as Mirena can be used as well in the patient with atypical endometrial hyperplasia. If a patient continues with progestin therapy, a biopsy should be repeated every 6 to 12 months to monitor for progression. Outcomes are generally good with a regression averaging 6 to 9 months. Current studies show a regression rate of 86% and a relapse rate of 23 to 26%. Polyps. Endometrial polyps are localized hyperplastic overgrowth of endometrial glands and stroma which form projections from the surface of the endometrium. Polyps are one of the most common etiologies of abnormal genital bleeding in both premenopausal and postmenopausal women. They may be asymptomatic also. The great majority of polyps are benign, but malignancy occurs in some women. Approximately 95% of endometrial polyps are benign. Polyps express both estrogen and progesterone receptors. Progesterone may serve as anti-proliferative functions as well as androgens. Most risk factors for endometrial polyps involve increased level or activity of endogenous or exogenous estrogen. A number of studies report an increased incidence of endometrial polyps in women on hormone replacement therapy. Endometrial polyp formation appears to be related to the type and dosage of estrogen and progesterone in hormone replacement therapy. A progesterone with high anti-estrogenic activity may have an important role in preventing the development of endometrial polyps. And obesity can be the risk factor. Endometrial polyps appear to be associated with obesity. Those women with a body mass index more than 30 had a significantly higher rate of polyps than other women. However, this data may not be generalized to other women. Polyps can be single or multiply and range from a few millimeters to several centimeters. In this picture, you can see a hysteroscopic view of uterus inside has two endometrial polyps. Several molecular mechanisms have been proposed to play a role in development of endometrial polyps. These include the monoclonal and endometrial hyperplasia, overexpression on endometrial aromatase and gene mutation. So polyps typically have dense fibrous stroma and contain clusters of thick-walled blood vessels. The cytologically is uniform throughout. Benign polyp lacks a consistent association between dense gland growth and a change in cytology. When EIN lesions occur within polyps, they have the appearance of localized lesion with altered cytology. Hyperplastic polyps often contains areas of simple and complex hyperplasia. Endometrial polyp fibrostroma harboring dilated glands lined by columnar epithelium. This is a picture of uterus, and you can see here on the fundus of the uterus the polyp, endometrial polyp. Endometrial polyps are typically identified in association with abnormal uterine bleedings. Many polyps are asymptomatic and rare discovered as a result of an evaluation for infertility, endometrial sampling, pelvic imaging, or hysteroscopy. In some women, a prolapse of the polyps occurs and it can be visualized at the external cervical os during pelvic examination. But for diagnosis of endometrial polyps is a histologic diagnosis based upon the evaluation of the specimen after it has been removed. Histological evaluation can also exclude malignancy. For diagnosis of endometrial polyps, ultrasonography can be used. During the ultrasonography, second fold of the lining of uterus may be interpreted as polyps on ultrasound scan. To make an accurate diagnosis, a hysteroscopy examination is often needed. The final diagnosis of uterine polyp is made when polyp is removed during hysteroscopy and sent to the laboratory. The laboratory confirms the presence of polyp and the type of polyp. Other diagnostic techniques such as salpingography may be used, may detect the uterine polyp, but it is important to take a tissue sample from the polyp and send for biopsy for rule out the cancer. So, once the polyp identified by ultrasonography or diagnostic hysteroscopy, investigation, transvaginal ultrasound, endometrial biopsy, dilatation and curettage, and hysteroscopy. Endometrial hyperplasia is often suspected in women presenting with abnormal uterine bleeding. However, confirmation of diagnosis requires histological analysis of endometrial tissue specimens obtained either by using miniature outpatient suction devices designed to blindly operate and aspirate endometrial tissue from the uterine cavity, by inpatient endometrial sampling such as dilatation and curettage performed under general anesthesia. Endometrial sampling is also fundamental in monitoring regression, persistence, or progression. So the biopsy is obtained through the use of endometrial suction catheter that is inserted through the cervix into uterine cavity, twirling the catheter while moving it in and out of the uterine cavity enhance uptake of uterine tissue, which is aspirated into the catheter and removed. Endometrial biopsy is useful in the workup of abnormal uterine bleeding, cancer screening, endometrial dating, and infertility evaluation. So after we do biopsy, we will send the material to histological examination, and we can when we will get answers, we need to know some important terms. For example, if we get answer complex atypia or simple atypia, we need to know the meaning of these terms. Simple means normal endometrial architecture but with increased glands and stroma. Complex means changes in endometrial architecture, crowding invaginations and or an increased gland to stroma ratio. And atypia, it's changes in the nuclear structure of the cells. Endometrial hyperplasia, one of the main steps in diagnosis is ultrasound examination. Transvaginal ultrasound scan detects an irregularity of the endometrial profile or an abnormal double-layer endometrial thickness. Measurement will give further reason to perform an endometrial biopsy in women with postmenopausal bleeding. Systematic reviews have suggested a cut of 3 mm or 4 mm for ruling out endometrial cancer and have shown that probability of cancer is reduced to less than 1% when the endometrial thickness is less than the cutoff. However, a large cutoff value has been suggested for women that taking hormonal replacement therapy or tamoxifen, whether presenting with abnormal uterine bleeding or asymptomatic. The role of ultrasound in premenopausal women is restricted to identifying structural abnormalities, as there seems to be an overlap between normal endometrial thickness and that caused by endometrial disease. For women with polycystic ovary syndrome and absent with withdrawal bleeds or abnormal uterine bleeding, transvaginal ultrasound should be considered as advised by all the World Health Organization guidance. So imagining the endometrium on days 5-10 of women's cycle reduces the variability in the endometrial thickness. In premenopausal women, normal endometrial thickness depends on stage of menstrual cycle, but a thickness of more than 50 millimeters is considered the upper limit of normal in the secretory phase. Hyperplasia can really be excluded in patients only when the endometrium measures less than 8 millimeters, yes. In postmenopausal period, a thickness of more than 5 millimeters is considered abnormal. The appearance can be non-specific and cannot reliably allow differentiation between hyperplasia and carcinoma. Usually, there is homogeneous smooth increase in endometrial thickness, but endometrial hyperplasia may also cause asymmetric focal thickening with surface irregularity, an appearance that is suspicious for carcinoma. These changes can also be seen in endometrial hyperplasia. So you can see here in this picture, thickened endometrium. And in this picture, you also can see hyperplasia in different women. The first picture, simple hyperplasia. Second picture, glandular cystic hyperplasia. And the third picture, complex atypical hyperplasia. Also, in diagnosis in endometrial hyperplasia, hysteroscopy can be used. Hysteroscopy with endometrial biopsy is known to be the gold standard for diagnosis of malignant and pre-malignant endometrial pathologies and related clinical conditions. Hysteroscopy allows the direct visualization of the endometrium and therefore the recognition of small and focal anomalies and their target biopsy, as opposed to blind sampling techniques, which showed a remarkable incidence of false negative, especially in cases of focal lesions. It is a hysteroscopic view of a typical hyperplasia. Once identified, polyps can be removed surgically through a hysteroscope. A removal polyp is advisable in all women with symptoms and in postmenopausal women. Uterine polyps, once removed, can recur. It is possible that patient might need to undergo treatment more than once if experience recurring uterine polyps. If the polyps are found to contain precancerous or cancerous cells are found in pollens, then hysterectomy, removal all of the uterus may be necessary. But the best way to treat polyp, of course, is polypectomy under hysteroscopic guidance. You can see here hysteroscopic view of the endometrial polyps in the uterine cavity. 1, 2, 3, 4 polyps. This is also hysteroscopic view, and this is one polyp in the uterine cavity. You can see here picture of polyp after polypectomy. So polyps can be single or multiply, usually sessile, measuring from 1 0.5 to 3 cm in diameter, occasionally large and pedunculated. When it comes to prevention of endometrial hyperplasia, it is important to remember that for women who use estrogen should take progesterone as well to prevent the unposed estrogen effect. Also, younger women with irregular menstrual periods should be treated with oral birth control pills that contains both estrogen and progestin in order to help regulate their cycle. And also, women should maintain a healthy body mass index. Those who are overweight or obese should lose weight accordingly.